Dr. Tulugu, and I'm here today to talk about patient 53826, Melissa Riveros. Before I begin, I would like to quickly introduce myself. My name is Dr. Tulugu, and I've been a pulmonologist in practice for 20 years, and I'm board certified in pulmonology and critical care medicine. So the patient care team that worked on this case consisted of the primary care physician, Dr. Martinez, myself as a pulmonologist, Dr. Ling as a cardiothoracic surgeon, and Mr. Ross as a pulmonary rehabilitation specialist. So Mrs. Riveros is a 68-year-old Hispanic female who retired 2 years ago from her job as a housekeeper at a hospice center. Her husband died 3 years ago due to a stroke, so she currently lives with her 32-year-old daughter, who is also her primary caretaker. For significant medical history, Mrs. Riveros was born through a preterm birth and had infant jaundice at birth, but this was relieved through phototherapy. The last major surgery she had was an appendectomy due to appendicitis. She currently has type 1 diabetes, but this is well managed through insulin therapy. And she had carpal tunnel syndrome while she worked, but this has mostly subsided after she has retired. Mrs. Riveros does have a significant familial history of type 1 diabetes, heart disease, and familial hypercholesterolemia, which were all taken into mind throughout the case. So Mrs. Riveros first came to see Dr. Martinez on November 3rd. She had a chief complaint of fatigue, but she also complained of mild shortness of breath, cough, as well as a general malaise. The vitals were taken, all were stable except for an elevated respiratory rate at 22 breaths per minute, as well as an acute pyrexia. The BMI taken at this time was normal. The blood sugar taken at this time was also normal, and a heat exam was mostly normal except for wheezing heard in her lungs. A complete blood work was also taken. CBC showed completely normal signs. A chem panel taken, part of the CBC, was also normal. The lipid panel was mostly normal except for a slightly elevated LDL level, but this was nothing to be concerned about. A glucose tolerance test was also taken, which was normal. So Dr. Martinez diagnosed Mrs. Riveros with acute cough as well as pyrexia, and she was given over-the-counter Robitussin for the cough as well as acetaminophen for the fever. And Mrs. Riveros was told to return in 2 weeks if symptoms did not improve. So Mrs. Riveros actually ended up coming back on the 11th of November. She actually reported that she came the previous day into the ER after collapsing on the floor due to severe shortness of breath. Luckily, her daughter was able to bring her to the ER where she was given the emergency corticosteroid budesonide and was able to breathe after given oxygen therapy for about 3 to 4 hours. Dr. Martinez performed a chest x-ray which showed obstruction in the lungs and a slightly elevated respiratory rate at 24 breaths per minute. Thus, Mrs. Riveros was referred to me. Here is the chest x-ray taken by Dr. Martinez. It clearly shows hyperinflation of the thoracic cavity as well as bilateral flattening of the diaphragms. So Mrs. Riveros first came to see me on November 13th. When I first saw her, she looked extremely fatigued. She had severe shortness of breath as well as a chronic cough. Doctors, please look at the SOAP notes that I have left in your folder. The breath notes were also not stable and they had evident stridor and wheezing. The respiratory rate was also 24 breaths per minute, and I held an initial prognosis of a respiratory ailment, but I needed to perform more tests to confirm my diagnosis. So, however, at this point, I did make a differential diagnosis consisting of both intrathoracic and extrathoracic diseases. For intrathoracic, I considered asthma, lung cancer, bronchiectasis, and alpha-1 antitrypsin deficiency based on the symptoms presented by the patient of difficulty of breathing, as well as extrathoracic diseases consisting of chronic allergic rhinitis, postnasal drip syndrome, and gastroesophageal reflux, as well as idiopathic chronic cough. However, I maintained the impression that it was an obstructive lung disease. So Mrs. Riveros came the following day on the 14th of November to see me to perform more tests. The blood test and thoracic radiograph were previously performed by Dr. Martinez, and I decided not to re-perform them. However, these tests did help me eliminate anemia, infection, and any other disease such as tuberculosis as seen by the chest x-ray. However, I did decide to do an alpha-1 antitrypsin test to see if there was a genetic lung disease, also a thoracic CT scan to look at specific blockage in the lungs, an arterial blood gas to look at oxygen and carbon dioxide levels in the blood, as well as spirometry to look at complete and comprehensive lung function. So here is a CT scan that I took. On the left, right is Mrs. Rivero's CT, and clearly it shows emphysema shown by the dark gray spots compared to the other one on the left. The arterial blood gas showed an acidosis of the blood with a pH of only 7.29. The carbon dioxide level was at 48.2 millimeters of mercury, clearly elevated from the normal level, as well as the oxygen saturation was at 81% compared to the normal 94 to 100. So this clearly showed that the patient had obstruction in the lungs. Finally, spirometry was performed, which showed a forced expiratory volume divided by forced vital capacity, simply known as FE1 divided by FEC ratio, as 0.56 compared to the normal 0.8 or higher. So this confirmed that there was an obstructive lung disease. I decided to re-perform spirometry after administering 400 micrograms of albuterol, and the FE1 divided by FEC ratio did improve to 0.73. So according to the Global Institution for Obstructive Lung Disease, this means that Mrs. Riveros had a stage 2 moderate lung obstruction. A CAT CAT scan was also performed, which had a score of 32 out of 40, which is extremely high. So my final diagnosis was chronic obstructive pulmonary disease, consisting of both emphysema and chronic bronchitis. The factors used in the diagnosis were the FE1 divided by FEC ratio, the CT scan, as well as the arterial blood gas test, as well as the symptoms presented by the patient, as well as their history working as a housekeeper. So now I'd like to quickly talk about the case definition provided by the Global Institution for Obstructive Lung Disease. COPD is caused by persistent respiratory problems causing airways disease and parenchymal destruction, ultimately causing structural changes, small airways narrowing, and destruction of lung parenchyma. So now I'd like to quickly talk about the pathophysiology of the disease. Here I have demonstrated through a model how COPD affects the lungs. On the right is a lung with COPD, and clearly there is hypersecretion of mucus seen by not enough air going through the bronchioles, as well as emphysema, which causes the alveoli to fuse, causing inefficient airflow. So this ultimately causes the difficulty breathing and symptoms of shortness of breath. So the different medication options are available for patients with COPD, and these were all presented to Mrs. Riveros. Some including oxygen therapy, both short-acting and long-acting bronchodilators, as well as phosphodiesterase 4 inhibitors. Interventions were proposed including lung volume reduction surgery, as well as a valectomy, and pulmonary rehabilitation was encouraged for the patient. Alternative medicine therapies were also introduced. Vasadi syrup and Swaskana Duma are both Ayurvedic medicine forms to help control coughing and wheezing associated with chronic bronchitis, as well as meditation and yoga to help the patient open up their airways and allow for more easier breathing. And in Chinese medicine, there's Xiao Xing Long decoction, which inhibits mucus hypersecretion associated with chronic bronchitis as well, and both show significant improvement in clinical trials compared to an alpha level of 0.01. The ultimate course of treatment taken was bronchodilators, short-acting beta antagonists, combining albuterol as well as ibuprotein, taken through a nebulizer 4 times a day, as well as a long-acting anticholinergic budesonide taken through an inhaler twice a day. The patient rejected a lung volume reduction surgery, however did approve a valectomy, and this was scheduled with Dr. Ling. The patient did consider pulmonary rehabilitation as well as the alternative medicine therapies proposed. So Mrs. Riveros came to see Dr. Ling on November 21st. So Dr. Ling performed a video-assisted thoracoscopic surgery, or VATS, valectomy, and this causes a removal of 2 bullae on the medial side of the left lung, as shown by the chest x-ray. And this caused a removal of 2 bullae at 24% and 31% respectively. There was slight pneumothorax and fluid accumulation, but this did not affect the overall results of the surgery, and the patient was able to recover within 4 weeks. Dr. Ling kindly left a video. Please note, viewer discretion is advised. They can see they're planning a resection of the bullae. Here they're finally removing the bullae. This was the removal of one bullae. This was repeated for another bullae. So Mrs. Ramirez was also recommended for pulmonary rehabilitation with Mr. Ross to learn more about the disease and create a custom diet and exercise plan for her. And she was told to go at least twice a week or as needed. Now I'd like to just talk about the global impact of COPD for us as healthcare professionals. COPD affects more than 328 million people worldwide and more than 12 million in the US alone. COPD continues to be underdiagnosed, undermanaged, and undertreated, and as health professionals, we need to look into new methods for further and earlier diagnosis of this disease. It currently stands as the 4th leading cause of death in the US and worldwide, and is expected to rise to number 3 by next year. The future of COPD includes a wide range of treatments, ranging from stem cell therapies, long-acting beta-2 antagonists, as well as long-acting muscarinic antagonists, which should be more efficient than current bronchodilators available, as well as IL-5 drugs. I thank you for your time, and I now open the panel for any questions.
All right, thank you. Now we'll be giving some time for the panel to give you some questions.
Great job. I might have missed this, but did you say what you thought was the cause of the COPD for the patient?
Yes, so as the patient worked with, as a housekeeper, the noxious particles associated with dust might have led to the COPD, as the patient did not smoke. So it was most likely chronic exposure to dust particles which led to this.
I just wanted to say that was a great presentation, and I really liked the part about the alternative medicine as a real life situation that I deal with. I do actually have cultural needs for patients that ask for that type of medicine, in addition to traditional Western medicine. And sometimes it's really hard to find, depending on who's treating the patient. That has come up in my own practice, and I really think that was a really extra special part of being culturally aware and also meeting real life patient needs in addition to that. I also really like the global impact part that you put in, because that really kind of brings it to a real life situation too. Great job.
Good.
Nice job. I really liked your presentation, as well as I liked the model that you made as well. Thank you.
The graphics were wonderful, and I liked your lungs. That was wonderful. Good job.
Thank you.
I have one more question. Sorry, this is something actually I do know quite a bit about, so I'm going to ask you a question. So I noticed that in terms of treatment, I didn't see anything in terms of steroid treatments. Was any consideration in using steroids at all?
There was no consideration for steroids as the COPD was only a stage 2, so the patient was primarily given bronchodilators. However, if the patients did not respond properly, we might have given her steroids in the future.
All right, judges. Give another hand. Now we'll go on to our third presentation.